We're moving on to Unit 9, which is pregnancy at risk and complications of pregnancy. We normally like to think of pregnancy as a normal event that the body is well equipped to handle, and generally speaking that is true. However, it does get complicated sometimes, and when there are complications, it can have pretty profound effects on both mom and baby. So we're going to discuss some of the typical things that can go wrong and how we manage them appropriately. This video is part 1, and it discusses diabetes in pregnancy, which is becoming a much more prevalent condition for us to see. Okay, so the objective in your outline that addresses this topic is to discuss the care management for the pregnant woman with diabetes. Okay? Diabetes is a very complicated disease, and it does impact fetal development, the growth of the baby. It impacts mom's future health, so it is something that we want to be familiar with. It used to be sort of an uncommon problem in pregnancy, but it is increasing in incidence as we are diagnosing type 2 diabetes earlier, and gestational diabetes has continued to become more common. So we'll move on. There are 3 basic types of diabetes that impact pregnancy. There is pregestational diabetes, which is comprised of type 1 diabetes, which I know you know from previous coursework, is an absolute deficiency of insulin. It's typically diagnosed earlier in life. And type 1 diabetics who get pregnant have serious risk factors. And one of the reasons for that is that they tend to have a longer duration of illness before they get pregnant. Type 2 diabetics are the majority now. For a period in time, it was uncommon to see type 2 diabetics get pregnant. But 2 trends have impacted the incidence of type 2 diabetes in pregnancy. And they are that women are bearing children at a later age, and that type 2 diabetes is seen in younger people because of various risk factors related to obesity, related to PCOS, related to increased fertility methods for women who have hormonal imbalances. So we are seeing more pregestational diabetes. And then there's gestational diabetes. Gestational diabetes goes away when the baby's delivered, typically. It doesn't start until somewhere along the 2nd to 3rd trimester, and it's caused by the insulin resistance that's created by the placenta. There's a hormone that's released called HPL, human placental lactogen. I know we touched on it briefly. We're going to talk about it again. But diabetes impacts about 7% of all pregnancies. So it is an important topic to talk about. So the key to promoting healthy outcomes with pregestational diabetes is going to be preconception counseling. And I want to show you something. This is a graph of the relationship between mom's preconception A1C, or A1C in the first trimester, to the risk of major malformations. And you can see here, when you're less than 8, your risk is about 3.2%. Typically for the general population, it is 3% according to the CDC, to have a baby with a major malformation. As you go up, when mom gets to be about 8 to 10, the risk goes up dramatically. And then as you get closer to an A1C of 10, it goes up to 23.5, which is a really dramatic increase. If you are above 10, if you're around 11, that gets up to, about 25%. And these are major malformations. We're going to talk about what kind of major malformations you get. And the first one we're going to talk about is neural tube defects. Neural tube defects are 4 times more common in the diabetic, pregestational diabetic, than they are in the general population. And some types of neural tube defects that we see are kind of even more complicated than the spina bifida. You do see spina bifida. But you also see anencephalic which is the absence of like most of the brain. So anencephaly, anencephalic babies are born to diabetic moms. You can see microcephaly, which is a small, like an undergrowth of the head. Oh, geez, I didn't notice that it auto-corrected me to something really strange, but okay. You can see caudal regression. So these are all neural tube defects that are much more common in the diabetic population than they are in the non-diabetic population. And so what do we do about that? We're going to target the pregestational diabetic for folic acid. Now typically we recommend that a mom gets 400 micrograms every day from preconception all the way to term. In the diabetic mom, we're actually going to increase that by a lot. And we're talking about 4 to 5 milligrams, which is, 10 times what we would recommend for anyone else. So 4,000 micrograms to 5,000 micrograms to prevent neural tube defects. And this is one of the reasons that preconception counseling is important, because again, by the time most women come for care to get this recommendation, the spinal cord is already perfectly formed. So at every patient encounter, if you have a patient who is of childbearing age and they have diabetes, whether type 1 or type 2, we're going to try and target them for preconception counseling, tell them that when they're ready to have their children, it's really important to seek care before they get pregnant. And we're also going to push that folic acid at every visit. Another major malformation that we see in the pregestational diabetic is cardiac defects. These are really common, and what we're going to do about this, again, is to caution mom to keep the blood glucose normal. And you saw in the graph that the higher you get, the more the risk. Typically, to prevent birth defects, mom needs to keep the A1C below 7, okay? And if you are a long-term diabetic, that could be a very difficult goal to attain. Ideally, you want it between 4 and 6. That's a non-diabetic number. Now, if they're between 6 and 7, their incidence is still slightly increased of major malformations, but not as increased. Now, the miscarriage rate of spontaneous abortion is also more likely. We also see an increased risk in stillbirth. And I think if most women knew this, they would definitely plan their pregnancies and they would seek preconception care, but it's a hard sell. Whenever they do the studies on whether moms get preconception counseling or not with this condition, they find that the incidence is very low. About 80% of women do not get any preconception counseling. What's important for a mom to know, or for any woman who's even considering having children, or any woman who could become accidentally pregnant, is that if you control your blood sugar, your risk goes down to that of somebody who never had diabetes. And again, that can be difficult, but they need to seek care. Sometimes it takes a good 3 months to get the meds right, to get that blood sugar under control. So definitely we want to encourage these moms to come in and seek counseling. Now, even if they manage to avoid these risks, there are other risks. We see uteroplacental insufficiency a lot of the times. Think about those diabetic feet you see in the med-surg patient. Think about the little vessels and the capillaries and all of that. And think about a placenta, which is basically almost a disposable organ. It's sort of a temporary structure. If you don't form those vessels right, or if you have poor vascular development in the placenta, you're obviously not going to nourish your baby. Also remember that every time the fetus has to break down the sugars, it creates a hypoxic stress. It's a little insult to the baby. Every time that sugar goes way high, it goes straight across the placenta. Remember again that the placenta is not this magic barrier that prevents all bad things from happening. Rather, it's a way to transport things. It's a highway. It's not at all a barrier. It's a way to get things to the fetus, not a way to keep them out. So when that sugar goes high, the fetus, even in the embryonic stage, the pre-embryonic stage, they're sort of safe because that's nothing really gets to them. But in the embryonic stage, they sort of soak this up like a sponge, and there's a chemical reaction that occurs, and it takes a lot of oxygen from the embryo or the fetus to combat that. And that happens all the way through pregnancy. And so you'll see things that look very non-reassuring in babies that have been exposed to out-of-control blood sugars. And so this is definitely something that we want to target. The other consideration for preconception counseling is medications. Now, once upon a time, we really usually saw type 1 diabetics who got pregnant. It wasn't that common. And those type 1 diabetics were all on insulin, and that was all they took. Insulin is a big molecule. It doesn't cross the placenta. It just doesn't go across. What it does is it lowers mom's blood sugar so that the sugar doesn't cross it either. So insulin is considered safe during pregnancy, but there are lots of medications for diabetes that aren't. They are using glyburide in pregnancy, but most of your sulfonylureas are not safe for pregnancy. Some of the medications are outright teratogenic. And so we want to definitely know what kind of meds mom is on and make those adjustments before she becomes pregnant. So if we can get mom, mom's a type 2 diabetic, get her off of the medications that might harm the fetus and get her onto an insulin regime that keeps her sugars down. And insulin's great for that because you can adjust it and really titrate it to get mom under control. That's the time that we want to do that. We don't want to wait until that 8-week period of organ development is completed. We don't even want to wait until week 3 or 4 is completed, because at that point we may have serious heart defects. We may have serious neural tube defects. So those are all things that you want to target for the pregestational diabetic. And a lot of your fetal surveillance is related to the things that we just spoke about. Now with cardiac defects, what you'll want to see a pregestational diabetic do is to go get a fetal echocardiogram somewhere between 16 and 20 weeks to see how the blood flow goes through that heart. I've had them with all 2 of my kids. The first one I wasn't diagnosed until halfway through the pregnancy at about 18 weeks. But the fetal echocardiogram will show you if there is a heart defect. And if there is, it might guide mom's decision making into going to a hospital that can perform heart surgery. She might get referrals to go see a pediatric cardiologist. And certainly the neonatal team will need to know about it before delivery. If this is a surprise, if you've got a woman who comes in and she's maybe 36 weeks, no prenatal care, had diabetes, and her baby has a heart defect, that could be a nightmare situation if you didn't know it. The baby will get cyanotic and decompensate shortly after birth, and if you're not vigilant for it, you could really have a poor outcome. So we'll do the fetal echocardiogram somewhere early in the second trimester usually. I think at some tertiary centers you can do it even earlier, like 12, 13 weeks. But a fetal echo is definitely indicated. Other things that we might want to do are like biweekly NSTs. When mom gets to be about 32 weeks, we want to know what that baby's doing. Is that baby reactive? Are they well oxygenated? Do they have a normal acid-base balance? So that's one thing we want to do. We're also going to want to follow up any non-reactive NST with a BPP, and we probably want to get at least one BPP, biophysical profile. Now, if you remember, the biophysical profile, we covered this in our last topic, which was antenatal testing, tests 5 fetal activities or characteristics of in utero life. Okay, so the first thing we looked at is the NST. You get 2 points or no points. You're reactive or you're not. So you have an NST, and that'll give you either 2 points or none. Then you look at AFI, which is the amniotic fluid index. If the AFI is within normal limits, you get 2 points. If it's not, you get no points. You want to see fetal movement. And these are discrete fetal movements. That's another criteria.
Going in the living room.
Chris?
I'm talking to the dog.
I know. Okay. So you want to see those discrete fetal movements. Fetal tone, and you want to see that active flexion of the trunk or extremities. You can review that in your textbook. We also want to see fetal breathing efforts. Okay, so these are measures of fetal well-being. See if we can make some of these letters smaller because I got more stuff to talk about. Okay, amniotic fluid index in a diabetic pregnancy. I think we kind of touched on this a little bit. Maybe we didn't. Amniotic fluid in a diabetic pregnancy can be either increased or decreased. Okay, so I cleaned some things up. Amniotic fluid index can be decreased in oligohydramnios. And diabetes isn't the only cause for that, but oligohydramnios, just like with any adult patient, renal output is decreased when there's decreased perfusion. So if that fetus isn't getting a blood supply from the placenta, let's say those vessels really aren't putting out enough blood flow to get to the baby, there's going to be decreased fetal urine. And amniotic fluid is made up of fetal urine, mostly. There are other constituents of it, and mom contributes as well. But when we see oligohydramnios, we know that there's really decreased perfusion to the baby, and therefore decreased blood flow to the baby's kidneys and decreased urine output. Polyhydramnios is the opposite problem, and polyhydramnios is more amniotic fluid than you're supposed to have. And this can also be common in diabetic pregnancy. And the reason for that is that the baby gets the sugar, and just like with anybody who's got an increased sugar, the symptoms are going to be similar. You're going to have fetal polyuria when they get that initial burst of sugar before their pancreas secretes enough insulin to bring it down. And that increase in fetal urine is going to make your amniotic fluid higher. And that puts mom at other risks. It puts her at risk for overdistension of the uterus, which could lead to preterm labor. I don't want to get too far ahead, but you just need to understand that this is why we look at these things in a diabetic pregnancy. She's at risk for rupturing membranes. With oligohydramnios, she's also, if baby's not getting enough nutrients to put out amniotic fluid, the baby's also not building any reserve to tolerate labor, and we're also worried maybe about some growth restriction. So those are some things that we look at. And in order to keep mom healthy, we look at some things. So maternal surveillance is important in pregestational diabetes. Okay, so let's go on to maternal. Okay, so diabetes is an abnormal state in mom, can lead to a lot of abnormal things. For one thing, we're going to look at mom's cardiac status. You study diabetes and you know that there are macrovascular complications of diabetes. It increases your risk of cardiac events and cardiovascular disease. So we're going to look at an EKG for mom somewhere in that first trimester. Also remember, if mom's got a cardiac status that's compromised and she has an excess fluid volume of 45 to 50%, now she's sort of at risk for worsening cardiac status. We do see cardiomyopathy of pregnancy is more common in diabetic moms, and it's rare to see congestive heart failure in pregnancy, but it's not impossible. So we do an EKG for mom. We might do a 24-hour urine to make sure that she's not putting out a whole lot of protein. Some moms with diabetes may have pre-existing kidney disease, which is a separate risk factor, but they're also at risk for preeclampsia. They're sort of sitting ducks for it, because if they have any sort of abnormality that's going to predispose them, and we'll talk about that more with preeclampsia, that underlying mechanism that causes vasospasm, there are chemicals that are sort of secreted in the presence of inflammation. Diabetics are more likely to have them. So they're sitting ducks for preeclampsia. And that's one of the things that we look at. We might look at thyroid function in some type 1 diabetics and some type 2 diabetics. There's an increased incidence of thyroid disease, and that can have impact on the fetus and the mom. So these are some things that we look at. But obviously we're also going to look at all of the vascular things. An eye exam is always indicated in pregnancy for diabetic mom. Sometimes we'll see those retinopathy changes at that point. Now, when we're talking about the pregestational diabetic in terms of what happens to them, what happens to their insulin needs during pregnancy? Well, during the first trimester, your insulin needs actually decrease slightly. Okay? So this is where mom might get some hypoglycemia, especially if she was going for super, super tight control during her preconception counseling. So this is the time that you want to really kind of tweak that. As the pregnancy progresses, of course, if her placenta is healthy, it's going to put out that HPL. So by the end of pregnancy, mom's needs triple on average. Now, it's one of those things where your mileage may vary, depending on how much weight gain the mom has and how big the baby is and whether or not she's got multiples or, just how insulin resistant she is in general. Her needs really have to be sort of titrated, but it is not uncommon to see moms at least triple what they need for insulin, and you'll see these mega numbers by the end of pregnancy, where mom might be maybe at the beginning of the pregnancy for every 15 grams of carbohydrate she ate, she was covering with 1 unit of insulin, and by the end of the pregnancy, for every 1 gram of carbohydrate, she's covering for a unit of insulin, or every 2 grams of carbohydrate. So, it's important for the mom to understand. Some things that we might do in terms of increased care. Mom will probably need more prenatal visits, better coordination of care, and this comes to adherence. Now, I can tell you from personal experience, when you need a whole lot of health care and you're a young mom, it can be really hard to get to all these different visits. They usually refer you to the diabetic educator. You're going to see a perinatologist, a nutritionist. You'll be referred for extra lab testing, more frequent ultrasounds. We do ultrasounds to check for fetal growth, among other things. You can also visualize the spinal cord usually really well and visualize the heart, like we said, with the fetal echo. So mom might get, an ultrasound every month. If she's getting a BPP with some of her NST, she's really getting a lot of ultrasounds. So mom is going to see she might have to see her primary care provider. She's going to see an ophthalmologist at least once, excuse me. She's going to have visits with her obstetrician. And this is an awful lot of stuff to do. If you have 2 or 3 kids already and you're going for all this stuff and you're trying to increase compliance, it can be really difficult to get mom to buy into all of this. On top of that, a diabetic mom who may have gotten a little bit of complacency going prior to her pregnancy is going to have to increase the frequency of her finger sticks. She's also going to have to report to the provider more often. Typically every 3 to 5 days they want to see your logs. More often if you're in a phase of adjustment. You're going to be adjusting that insulin frequently. She might even have to be in daily contact with her provider. And then there are all the supplies. Sorry. She's going to have more test strips. If she was pre-gestational and she was controlled on oral meds, now she's going to have to use insulin. But the positive aspect of this is that most providers who get frustrated working with diabetics actually prefer to work with the pregnant ones because they're highly motivated by the outcome. It's just a lot of education. When people understand what the stakes are, they tend to be much more adherent to their regimen. So moving on to gestational diabetes, about 90% of diabetic pregnancies fall in this category. The incidence could be, and it varies by where you live, incidence could be anywhere from 1 to 14%. Are complicated by gestational diabetes. Now, I know I said about 7%. It really kind of depends on whose study you go by, but it's not an uncommon problem. And gestational diabetes is an impairment in carbohydrate metabolism. It first manifests during pregnancy. Now, we talked about how human placental lactogen sort of antagonizes insulin, but women with a healthy pancreas and no propensity towards diabetes of any kind will not develop gestational diabetes. Most women don't. Their pancreas just secretes more insulin and meets the need. But if there's any sort of abnormality there, any difficulty that might be dormant when they're not pregnant, when you stress that pancreas out, it can't keep up. It develops in the later half of pregnancy. And I want you to sort of understand that when it develops earlier, appears to develop, what we're really looking at is an undiagnosed case of type 2 diabetes or even type 1. Sometimes they can sort of figure that out. It is a result of the altered hormones, and usually mom doesn't get too many symptoms, and what she gets are sort of masked by normal discomforts of pregnancy. Maybe she's thirsty and hungry, but maybe she would have been thirsty and hungry anyway. She just thought she had an increased appetite because the baby was growing. And maybe she's tired, but in third trimester, remember, people get fatigued. Maybe she's got urinary frequency, but if she's in the first or third trimester, if she's in the third trimester, that develops normally. So generally, and moms with gestational diabetes really aren't at too much risk for themselves. It's really the baby that we're concerned about. So they are at risk for developing diabetes later in life, and the incidence of that really varies with which study you go with and how long they follow. If you follow somebody 25 years, the risk goes up to like 72%. If you follow them for 3 years, it might be 30%. But it's high. It's really high. It's much higher than what the general population is. And what's happening is that you're unmasking some defect of either insulin secretion or insulin resistance at a time when the pancreas is stressed. Okay, so the way that let's talk about the risk factors first, and then we'll talk about diagnosis. So risk factors for gestational diabetes. Okay. Here we go. Okay. So age over 25, and that's most of your pregnant women. So that's one of the reasons that we are screening everybody with that glucola test, which we'll talk about. Sorry. Obesity. Obesity increases insulin resistance. It messes with some more hormones like leptin and ghrelin and all that. But obesity, you know from your other lectures, is a risk factor for type 2 diabetes. Insulin resistance. There are women who are insulin resistant. And you see that with PCOS a lot. PCOS is polycystic ovarian syndrome. Now, sort of an interesting thing, maybe one of the reasons we see more gestational diabetes and type 2 diabetes is that women with PCOS typically don't get pregnant without intervention. it is a major contributor to infertility. It's a hormone imbalance that has to do with increased androgen secretion from the ovaries. And what happens is you get you have insulin resistance, you have this increased androgen secretion. The woman gets features like hirsutism, which is excess hair growth, weight gain, which contributes to insulin resistance. They have issues with skin. They sort of get that hormone imbalance, a little bit more masculinized. And that obesity that they get typically is a truncal obesity, or more in the abdomen. It's more male pattern obesity. So PCOS contributes to insulin resistance. Now that we use different agents to help people get pregnant, you're seeing an increase of women with PCOS who get pregnant and carry to term. So their increase for gestational diabetes is increased. If they had a previous complicated with GDM, that's a risk factor, obviously. If they have a history of a large for gestational age baby, LGA baby, these are moms that maybe had levels of blood glucose that weren't enough to diagnose with gestational diabetes when they were tested, but maybe they really had some sort of like subacute type of gestational diabetes. So this is defined as a baby who is greater than the 90th percentile, typically looking at kids that are about 4,000 or 4,500 grams or larger. Any sort of stillbirth, miscarriage, or infant with a congenital anomaly, and that is, again, this is probably a mom who had some sort of carbohydrate intolerance prior. Let me just shrink that a little bit so we have more room. Prior to another pregnancy. Remember that stillbirth and miscarriage and major malformations are more common with diabetic pregnancies. We're also looking at women with a history of first-degree relative with type 2 diabetes. So if their mom, dad, brother, sister had any sort of diabetes, they should be screened probably earlier and maybe more than once during a pregnancy. And the last thing that we look at is ethnicity. And as far as ethnicity goes, we're looking at African American patients, Hispanic patients, particularly people from Mexico or Central America, and Pacific Islanders, people from the Philippines, people from any part of the Pacific Islands, Asian Americans, and the Native American population, which has an extremely high incidence in many of the tribes, Alaska Natives too. And so these are people at risk. It's basically every non-Caucasian population. Now, even given that the risk is higher in these populations, the incidence of gestational diabetes is growing in all segments of the population, and so the recommendation now is to really test everybody between about 24 to 26 weeks. So we'll start talking about the complications of gestational diabetes. As I said, mom's risk is low, but she does have a risk. Her big risk are the risk for cesarean section or operative vaginal delivery. And to be honest, a lot of providers are very reluctant to do an operative vaginal delivery on a mom who has diabetes because of the risk of shoulder dystocia, which can be bad for the baby. Also, if that baby is big, you have pelvic floor injury, and then there's the risk of postpartum hemorrhage. And I know you guys had a lab on postpartum assessment. And the risk factors for postpartum hemorrhage, if you think about it, are all related to basically 4 factors. You have a decrease in tone, which is uterine atony. And tone can be compromised when you have an over-distended uterus, when you have multiples, when you have a big baby, when you have polyhydramnios in a big baby. You distend that uterus. Think of the uterus that has muscle fibers that are very similar to like rubber bands. And think about the rubber band that's on broccoli. It's nice and tight. And if you try to, overstretch it, it doesn't do it. It won't, but it snaps right back. When you get one of those loose-soled rubber bands that has been wrapped around things over and over, it's been stretched way out, it doesn't want to snap back, so that uterus doesn't contract effectively and you get a hemorrhage as a result. And so that is one mechanism where we might see that. The pelvic floor injury could also be due to the increased need for episiotomy. So those are some risks to mom. Also, if she has a baby with a lot of fluid, she can have what's called PROM, which is premature rupture of membranes. And if that situation continues, she's at increased risk for choreo, which is an infection. Chorioamnionitis is the long name for it. And that's really an infection that's found when you have ruptured membranes for a long period of time. So those are the maternal risks, but really it's the baby that sort of suffers the most from gestational diabetes. The big thing that we see is macrosomia. These LGA babies. LGA means large for gestational age. And here we're looking at like 4,500 grams. And that's a big baby. Because they're big, if they deliver vaginally, they are at increased risk for shoulder dystocia. Generally speaking, when a baby comes out, their heads are bigger than anything else. So the head sort of paves the way, the shoulders slide right out. It could take you a really long time to push out the head, even if you're crowning, if you're a first-time mom. The shoulders should really be the next push. And there shouldn't be any difficulty. Well, in an LGA baby, or macrosomic diabetic baby in particular, the head isn't always the biggest circumference. Sometimes it's the chest, the abdomen that overgrow, and that's because of the way that their fetal insulin is depositing that fat, so they can have a bigger circumference and their shoulders get stuck. When the shoulders get stuck, two things can happen. You can have fetal asphyxiation because the head delivers, the cord's compressed, it's in the birth canal, you're not getting effective blood supply to the baby, and yet you can't really do anything about it, they're stuck. You also can have brachial plexus injury or fractures of the clavicle. And brachial plexus is that bundle of nerves in the upper extremities where the brachial arteries would be, in that general area, because you can have compression injuries when you're trying to deliver that baby. And you can have the fractured clavicles for obvious reasons. Sometimes they even have to break the clavicles to get the baby out. They try really hard not to, but that's what happens with the shoulder dystocia. So with that, you also have, with diabetes, you also have a delayed fetal lung maturity. And the placenta ages. And I'm going to put these together because I want you to understand something. You can't keep diabetic moms pregnant forever. They can't just go past their due date, la-di-da. That placenta gets older. The higher the sugar and the higher the insulin, the faster that placenta is going to age. So if you have a baby whose lungs don't mature because the chemicals that help the lungs mature in the urine are diluted by a lot of amniotic fluid, and you have an old placenta that doesn't want to give them anything, now you're in sort of a catch-22. If you deliver too early, you're going to have a baby that doesn't want to breathe, and they can go into respiratory distress. If you wait too long, that placenta starts to deteriorate, and that's where you get your increased incidence of stillbirth and your increased incidence of cerebral hypoxia. So this is where, you're sort of in that catch-22, and towards the end of a pregnancy, a diabetic mom will be referred for lots and lots of additional testing. She's going to go for NSTs at least twice a week. Fetal kick counts become important because that fetal movement is important. She's going to see her provider probably twice a week. And she may need an amniocentesis for that LS ratio that we talked about, because this is a game. It's what's the best outcome. You don't really want to deliver before 39 weeks if you don't have to, but you might. You might have to. That placenta might not be giving that baby enough nutrients. So if you're getting non-reactive, non-stress tests, or if you're getting really crazy macrosomia, it looks like the baby's already 8+ pounds at 36 weeks, we're going to want to take a look at what the optimal time to deliver is, and that's really going to be a decision that a provider makes based on all of the risk factors. And so this is one of the reasons that we want to really keep on top. Okay, so we're going to back it up a little bit and talk about how we detect gestational diabetes. And so the American Congress of Obstetrics and Gynecology, that ACOG organization, has recommended that all women be tested for gestational diabetes at 24 to 28 weeks. And it's going to be at whatever appointment that would coincide with. Remember that mom is coming for care every 4 weeks at this point if she's on a typical schedule. If she has some of the major risk factors, if she's got a BMI over 30, if she's got a history of gestational diabetes in a prior pregnancy, they will screen her earlier in the pregnancy, but at that point, it's usually considered a pre-gestational diabetes. And I've seen them screen as early as 12 or 13 weeks. And the test that we use for this is called an oral glucose tolerance test, or a GTT, or even an OGTT. And how we do it is we give mom a 50-gram glucose solution. And it's pretty nasty. It looks like orange Shasta. It tastes really, really, really sweet. It's the kind of thing that might make a mom really nauseous, especially if she's sort of still suffering from that. She should be over morning sickness by that point, but some moms still get a little bit queasy. After she takes that solution, now remember she has to chug it, and it's like a 12 to 16 ounce bottle. I can't remember off the top of my head, but it looks like if you were to get a Diet Pepsi out of the machine. An hour after she drinks it, and she can't eat or drink anything in between, we check the serum glucose. Okay, this is not a fasting test, by the way. Mom can eat her lunch and then come in and drink the glucola, because we work on the premise that a healthy, normal pancreas without any compromise is always going to keep the blood sugar below 140. Typically, unless you're on steroids or something weird happens, if you're walking around, you could eat, any number of carbohydrate-containing foods. If you have a pancreas that's functioning at its optimal level, it's going to keep your sugar under 140. It'll just secrete more insulin. So a positive screen, and this kind of varies from like one provider to another. It could be 130, as low as 130 to 140 milligrams per deciliter. 140 used to be the absolute cutoff, but there were a lot of providers who seemed to think that we were missing some cases, and I do think that there's a good argument to be made for that. If you're screening the mom at 24 weeks and maybe she's not at her maximum insulin resistance, and you're getting 137, and then she has a 9.5-pound baby, maybe we just didn't catch her at the right spot. And maybe she was subclinical. So if you get a positive screen, that's not a definitive diagnosis. We need to get mom a prescription to go to a lab to get a 3-hour screen. This is a fasting test. And typically mom's going to need to make an appointment with the lab to do it because it's sort of a special arrangement. She needs to come in, no smoking, no drinking coffee, nothing, just water. And they give her a 100-gram solution. And if you thought the 50-gram one was no fun, the 100-gram solution is really pretty gross. Now, I have the values that are considered to be normal during pregnancy. You do see a little bit of variation. It's fasting should be less than 95, 1 hour less than 180, 2 hours less than 155, and 3 hours less than 140. Two abnormal values indicate gestational diabetes. Now, let's see. There is a new protocol that is sort of up for debate. You may see it in years moving forward. But the International Association of Diabetes and Pregnancy Study Group has a recommendation. It hasn't been adopted by ACOG yet officially. It is a it's a one-step protocol. This 1 hour screen and then the 3 hour screen is considered the two-step. So the one-step protocol uses a 2 hour glucola with a 75 gram solution. So that is another test that you might see moving up in the future. And the result that would be positive for that would be anything over 140 as a cutoff. And then we would start to treat for gestational diabetes. Okay, so now we're going to talk about the management, what our target goals are, and how we're going to achieve those goals. So with gestational diabetes or any other type of diabetes, what we want is a fasting glucose within the normal range. Now, depending on who you ask, that range could be 65 to 105 milligrams per deciliter. But more commonly what you'll see is below 95. You'll even get some docs that want it below 90, but that can be difficult to achieve. Not impossible, but difficult without putting mom at risk, especially with insulin, putting mom at risk for hypoglycemia. Now, I'm going to put post-meal. The real word is postprandial, but I have been fighting with the autocorrect, and I have no idea what it'll come up with. So 2 hours postprandial should be less than 120, okay? When mom is getting more than 120, on a couple of occasions, she should really let her provider know, and they can adjust her treatment plan. We want really, really tight control. Like I said, if the fetus has to put out a lot of energy to deal with the blood sugar being high, they're suffering stress and hypoxic insult. So those are our target goals. Now, for moms that have diabetes, diet is almost like a medication. So we're going to be very careful about the diet. Exercise will help with insulin resistance by getting the skeletal muscles to take up, to be more sensitive to that insulin. And so we want to counsel mom to exercise within the boundaries of what's safe for her. Walking is always okay unless, there's some reason that mom absolutely can't walk. She has a knee injury or something. She can swim. But generally, mild to moderate exercise really does help with glucose control. So we are going to counsel mom about exercise. As far as diet goes, there are a couple of different recommendations out there. We used to use what was called an ADA diet, and that was prescribed. The provider would look at the woman's weight and prescribe a calorie limit. Typically, with the obese moms, you'd see 1,800 calorie ADA diet. You could see 2,000, you could see 2,200 with twins, especially in a very active woman or in an adolescent pregnancy, you might go up to 2,400. And you'll probably still see that in some practice settings. Where I work, we're doing more of what's called a consistent carbohydrate approach. And even in the ADA diet, for pregnancy, it was really encouraged that mom remain consistent with both the timing and the content of her meals. You don't have to eat the same thing every day, but similar amounts of carbohydrate. So the old ADA diet was based on exchanges. The new CCD diet that we're using where I work is very similar. It's just that they don't really control for the calories as much or for the proteins or fats or anything like that. But basically you're going to want to have smaller, more frequent meals so that you're spacing out your carbohydrates. It's typical to have like 3 meals and 3 snacks. Okay, just leave it there, I'll get it. 3 meals and 3 snacks a day, and they should be spaced like every 2 to 3 hours. That mom should be eating something, so that she's not overloading her body with glucose or carbohydrate in any one meal or snack. But if she's, her carbohydrate needs, her dietary needs will still be met within that 3 meals and 3 snacks. Now you might see the carbohydrate limit could be like 30 for breakfast, 45 for lunch, 45 for dinner, and the snacks could be 15 to 30, and that's usually worked out between the dietitian and the provider. But basically, your emphasis is going to be on high quality food, because you're going to be limiting. The mom's not going to be able to eat whenever or whatever she wants. You want to encourage vegetables, whole grains over refined grains, definitely. We're talking about portion control. This mom needs to measure everything she eats. When we talk about that consistent carbohydrate portion, or even on the exchange diet, a serving of rice is 1/3 of a cup. Now, if you're at home and you have access to a set of measuring cups, I want you to look at how much rice that is. Measure that out a couple times and see it's really not a lot of rice when you're used to eating a cup of rice, or cup and a half at a meal, or pasta. 1/3 of a cup really seems like almost nothing. And so you really want to caution mom to be careful about weighing and measuring. Even bread, she really should look at the slice of bread and read the package and make sure that she's eating the same number of carbohydrates at each meal, and it's within what her provider wants her to eat. Like I said, you may still see the exchange, the ADA diets, but the important part to control is the carbohydrates. You also want mom to make sure that she's not really drinking a lot of her calories. Instead of juices, we want whole fruits. Because that kind of helps the blood sugar stay normal. So that is, like in a nutshell, the diet that you would recommend for most moms. Now, if diet is not enough to control mom's sugar, she's not meeting her targets, then we have to start talking about medical management. Now, the drug of choice for a long time was insulin. And usually we do a combination of longer acting insulins and shorter acting insulins. So one combination you might see, could be like a Lispro or Aspart insulin, and this would be preprandial injection. And then you would have a longer acting, like a glargine insulin, like Levemir or Lantus at bedtime. That could be one way of handling it, and it usually works quite well. You could also use an insulin pump. In a patient who is motivated, particularly your type 1 diabetics who might already have a pump, sometimes your insulin pumps also incorporate a glucose monitoring sensor. And it'll kind of help mom regulate her sugar very well. But for most gestational diabetics, you're not going to really be using insulin pumps. They're only going to be pregnant for maybe another, 10 or 11, probably more like 12 or 13 more weeks if you pick them up at around 25 to 26 weeks. So you might not want to do an insulin pump for somebody who is just a gestational diabetic detected on a normal screen. You might also see a regime with regular and NPH insulin. Some perinatologists favor this, and what they would do is do about 1/3 of a dose as regular at breakfast time, and 2/3 of the dose would be NPH insulin. So if you had, say, 6 units to cover your breakfast of regular insulin, and then 12 units of NPH to cover you for the rest of the day until dinner time, and then you would get more NPH at dinner time to cover you through the night, so that your fasting would remain nice and low and a little more regular to cover that dinner because the NPH may wear off at that point. So those are some regimes you might see. Now, one of the problems that we have with insulin administration, you know this from being in the hospital and dealing with med-surg patients, is that whenever you use an agent that lowers the glucose by promoting the, by adding insulin, you can get hypoglycemia. So we, in addition to teaching mom how to inject insulin and how to monitor her blood sugar with the blood monitor. If she's a gestational diabetic, this is all new to her, especially if it's the first time she's been diagnosed. We're going to need to teach her the signs and symptoms of hypoglycemia so that she knows to report those and she knows how to act. Now, treating hypoglycemia, we don't want to overcorrect it. We don't want some rebound hyperglycemia. So we teach moms to correct with skim milk or low-fat milk, like 1% milk. And this has the advantage of correcting that sugar pretty rapidly. That lactose will act fairly fast, but the protein in the milk will help prolong her, prolong that effect so that she doesn't get hypoglycemic again. Instead of using juice, which will maybe have it rebound a little bit too high, or instead of having her use food, she should know that she corrects with 1 8-ounce glass or container of skim milk or 1% milk. Something else that we might want to teach mom is to have her family recognize the signs and symptoms of hypoglycemia and have glucagon available. And let me, I know you guys already had this in other content, so it's not brand new to you. But let's just put it out there. So that way you can take the notes, and if you had to make a care plan or do something along those lines or answer a question about what to do with the mom on insulin, you would have that. Okay, so those are some things that go along with treatment with insulins. Now, I said for a long time it was the only treatment. We never used any oral hypoglycemic agents in pregnancy. When I was a student, we were told that they caused horrible birth defects and nobody ever used them, but we are now using some of them. In particular, I have seen the use of glyburide increased. Wow, fly buried. Okay, no. Glyburide. And glyburide is, you remember this, a sulfonylurea. And it helps. The action that it uses is to increase secretion of insulin by the pancreas. Okay, so that's glyburide. And glyburide is good for a couple of reasons, and one of them is that it is easier for some women to take the pill, but the other thing is that women without health insurance, even though they get access to care through the clinic, it can get very expensive to buy the test strips, the needles, the insulin itself. A box of pens for Novolog insulin, incidentally, is almost $400 out of pocket. So if you are, say, an undocumented patient and you don't have any health insurance, you're going to the clinic and they say, go get this box of pens, you don't have $400 for that, and especially pregnancy doesn't last that long. So, and on top of that, if they have to get 2 different types, it's $800. They only last for, as long as they last. So, it may be better in those cases to put them on something oral, as long as it's effective and it helps them reach their targets. So, side effects of glyburide, basically, it's the same as insulin. You're really going to teach mom to monitor for signs and symptoms of hypoglycemia. And she still needs to check her blood sugar to make sure that that medication is effective. Now, one last topic that I would like to cover before we end has to do with the baby. After the baby is born, we want to monitor for certain complications. We had talked about macrosomia, which places the baby at risk for birth injuries, such as the shoulder dystocia, brachial plexus injury. But we also want to look for hypoglycemia. Now keep in mind, if a fetus is used to getting big shots of sugar through the placenta, high glucose, the pancreas is used to pushing out lots and lots of insulin. And it can take a little while for that insulin to act. So if mom's sugar in labor is, let's say 200, the baby still has some insulin on board. The baby's born, that sugar, that pipeline that's feeding the baby all that glucose now is cut off, and the baby still has large amounts of circulating insulin. And it can take a little while for the baby to really be able to regulate their own blood sugar, so we need to monitor the blood sugar. So that's one of the things that we need to look for. We're also going to monitor for, and this all gets covered again in newborn, but I just want you to be aware of why diabetic pregnancy can be problematic for the baby. Hyperbilirubinemia, otherwise known as jaundice, it leads to jaundice. That jaundiced appearance of the newborn. And what happens there is that in response to all those little hypoxic insults, the baby starts to make more red blood cells to carry more oxygen. It's a compensation mechanism. So you get babies that are born with a lot of polycythemia, and you can tell when you see them, they're very, very ruddy. They're very red. When those red blood cells start to break down because they're no longer needed, you get release of bilirubin, which is the pigment that's responsible for that yellow coloring. Jaundice proceeds from head to toe. It is usually worse on the second or third day. But these babies can get very sick, and they can get kernicterus, which is a complication. And you'll learn more about that in newborn. I don't want to beat it to death now. And the other thing we want to look for, and we kind of already touched on this, respiratory distress syndrome. And the reason that this can happen, and we already talked about it, fetal lung maturity is delayed in infants of diabetic mothers. It has to do with the chemical milieu inside the amniotic fluid. When babies breathe, they have those fetal breathing movements. They're not breathing air in utero, they're breathing amniotic fluid. And there's a chemical that acts directly on that tissue in the lungs and helps with the lung development. So infants of diabetic mothers can be term and still have relatively immature lungs. So that is one of the things we want to watch for. And keep in mind that the incidence of fetal compromise or newborn compromise is directly proportionate to the amount of glucose control you have in pregnancy, and that's the message you want to give to your antepartum patients. So when we meet in class to discuss this content on the 21st, we can clear up any muddy points. So bring your questions and let me know what it is that I can clear up for you. Thanks.